All right, welcome to our Nutrition Talks webinar series. My name is Tavis Piatoli, healthcare account educator, dietitian for Omega Quant. We're going to get started in just a few minutes. We're starting to see a lot of influx of people starting to come into the room. So we usually like to, we know people are breaking for lunch in certain parts of the world and different, regions. So we just want to give them a little bit of time to break, kind of get into the room. So we'll be getting started in just a few minutes. Before we get started, if you have a question for Dr. Harris, there is a Q&A section. Anytime throughout, you can put that question in the Q&A. I'll be moderating. We're going to try to get to as many questions as we can before we get to the top of the hour. We're going to try to keep this around 40 to 45 minutes and then open some questions for you. Sometimes these things go a little bit longer. And then at the end, if there's questions that we cannot get to, I'm going to provide my email address. You can email me directly, and then we'll get those questions submitted to Dr. Harris for your answer. Also, our next Nutrition Talks webinar is scheduled for Tuesday, September the 18th at 12 p.m. Central Time. The current topic is plant-based omega-3s. Once we finish confirming the speaker, that will be available, and we'll get that registration page sent out. The recording for this, once our team gets a chance to do all the edits and shape up the recording, I'm going to get that sent out to everyone who is registered for this. So just, if you don't get it right away, it might come late this week by Friday, maybe early next week. It just takes our team a few days to go through that and get that designed. Also, be sure to check out Omega Quant University, which is courses, videos, blogs on all of our education. We have what's called Omega Matters. These are 40 episodes and counting where we interview different professionals in the omega-3 space. So I'll be putting the links of that as well in the chat. It's on our website. And then also our healthcare provider education program. And then we have a YouTube channel now with over 250 educational videos about omega-3 and omega-3 testing. So pretty much when I meet with practitioners, I get a lot of questions about different topics. I got one this morning when we spoke to a practitioner out of the UK about what's your concerns about omega-3 and bleeding. And so I invited her to join this live presentation. So we'll just give it another 30 seconds before we get started. Before we get started, let me give you a little bit of an overview about Dr. Harris. He is the president of the Fatty Acid Research Institute. He's been a leading researcher in the omega-3 fatty acid space for over 40 years. He has more than 360 scientific papers on fatty acids and health, and the vast majority on omega-3. He's been on faculty of 3 medical schools, the University of Kansas, Missouri, and South Dakota, and has received 8 NIH grants to study omega-3. He was the co-author of 3 American Heart Association statements on fatty acids and heart health, as the co-inventor of the omega-3 index and other omega-3 blood tests, and founder of Omega Quant Analytics. He's been ranked among the top 2% of scientists worldwide based on the impact of his research. Dr. Harris, thank you so much. We're really excited about your presentation today.
Thank you, Tavis. Good to be here. Talk about a fun topic. All right, let's get going. Topic du jour is, of course, omega-3 fatty acids risk for bleeding, and I've added in there the myth versus the evidence, because I think there is a lot of myth going around and quite a bit of evidence that it is a myth. So we'll move into this. Let me get this advancing properly. I'm going to start with a historical perspective, then we'll look at some observational epidemiology, different kinds of evidence, non-randomized trials, randomized, some meta-analyses, risk for stroke, which is, of course, the biggest concern about bleeding. And then I thought we'd quickly go over the prescribing information for the 2 omega-3 drugs to get the intake or the take of the Food and Drug Administration on the bleeding risk. And then I have a closing anecdote to end with. So historical perspective. I guess the question is, why would we think omega-3 fatty acids might increase risk for bleeding? Where does that even come from? And it comes from pictures like this. And I want to thank Dr. Jorn Dyerberg, the scientist who really started the entire omega-3 story, for providing this picture for us. And I believe he's on the call today, too. So hello, Jorn, if you're there. Here is a Eskimo or a Inuit boy from Greenland who was having a nosebleed. I don't think this necessarily killed him, but it makes the point that there's a lot of bleeding among the Eskimos. And that's kind of what started the story. Based on this kind of work and much additional work that Dr. Dyerberg and Bang did in the 70s, when they were creating this whole omega-3 field, was they looked at the omega-3 intake of Inuits, and in this particular community, it was roughly 13 grams per day of EPA and DHA, which is huge, obviously. And so that needs to be taken into account. Based on their work, I think they published, 1978, a landmark paper in the Lancet. The title of it was EPA and icosapentaenoic and the prevention of thrombosis and atherosclerosis. So this was a kind of a hypothesis paper that grew out of their studies in Greenland. What they showed, they actually took EPA and compared it to arachidonic acid as a activator of platelets, which is part of of course, the clotting issue, thrombosis. And in this particular graph, it's what you see here is under column A is a tracing of what happens to platelets when you add arachidonic acid to them. And the more these curves go down, the more the platelets are activating. They're aggregating. So here's 3 different doses of arachidonic acid added to human platelets, and they got a lot of aggregation. They added, in column B, they added EPA at even much higher concentrations and didn't get any reaction at all. So this was a real eye-opener, and this suggested that the omega-3 EPA particularly was anti-thrombotic. And then with the help of Dr. Vane in Moncada, John Vane actually discovered prostaglandins. He and others got the Nobel Prize in '82 for that. But they worked together with Dr. Bang and Dyerberg to show that the arachidonic acid, the omega-6 version, produces in platelets thromboxane A2, which is pro-aggregating, but EPA does not produce an aggregating thromboxane. It's a neutral. So there was, in this particular balance, there was less aggregation caused by the omega-3 fatty acids. And they concluded their kind of landmark paper with Eskimos have high levels of EPA and low levels of arachidonic acid. And they also have low incidence of myocardial infarction and a tendency to bleed. It is possible that dietary enrichment with EPA will protect against thrombosis. And this really set the field on fire, I think, and was the basis for certainly some drugs that were developed early for just EPA. And anyway, this is why we think omega-3s might cause bleeding, because they do. Well, I was lucky to get into this game fairly early. Here's a paper we published in 1981 where we were feeding not Eskimos, but normal Americans, volunteers, high doses of omega-3. And so I thought I'd just mention here, we have a salmon diet. A salmon diet was essentially identical to the control diet in this study, except that almost all the dietary fat and all the cholesterol were delivered by salmon steaks. So we fed 1 pound a day for 30 days of salmon, and we gave the individuals in the study 60 to 90 milliliters per day of salmon oil. Each subject then consumed about 10 grams a day of EPA and DHA. So this was a high-dose study, approximately the dose that the Eskimos were eating, but it was done in a controlled dietary setting at the University of Oregon, where we were doing this study. What we found here was the platelet count and the bleeding time were 2 things that we measured. Platelet count dropped a little bit, still really within the normal range. Bleeding time increased, and the bleeding time is a test we used to do. It's not done much anymore, but we actually put some tiny cuts on the forearm and to see how long it takes them to stop bleeding. And we started out well within the normal range and came up a little above the normal range, again, with 10 grams a day of EPA and DHA. So this is part of where we know omega-3s do increase risk for bleeding or increase bleeding times. But what about lower doses of omega-3? Here's a study, a very small study we did, but we were comparing aspirin to fish oil. We gave people 4 days of aspirin, 2 weeks of fish oil, and then did both of them together. And we looked at its effects on bleeding. Here we're talking about 4.5 grams of EPA DHA, which is still a little bit high, but it's certainly within the range of what we've seen in clinical trials. If you compare the control group and all the metrics of platelet function compared to the fish oil group, or the fish oil period, same people, there was no meaningful difference between them, especially look at bleeding time, 6.4 minutes in control, 7 minutes on fish oil, 4.5 grams of fish oil. So even in this experiment, there was really little effect of omega-3 on bleeding. Aspirin had a much larger effect. Here's aspirin alone, aspirin plus fish oil. But these are some of the reasons why we think omega-3s would cause bleeding, and that's what kind of set the tone back in the early 80s for omega-3s being concerned about bleeding. So that's a little historical perspective. Let's now get into a variety of data, starting with epidemiology, to look at the relationship between fish oil, omega-3, and bleeding. So here's a study that we did when I was in Kansas City. We had 1,500 patients who were admitted to the hospital with an acute myocardial infarction, and we tested all of them for the omega-3 index. And during that hospitalization time, we looked at risk for bleeding as one of the things that occurs post-MI. And this figure here, which is, I know it's a little small to see, but this is looking at the relative risk for increased bleeding as a function of a variety of different factors, number one being the omega-3 index. And so if you look at a per 2-point increase in the omega-3 index, say going from 4% to 6% or 6% to 8%, there was no effect whatever on risk for bleeding. That's why that dot is right on that red line. And so we concluded in this paper, no relation was found between the omega-3 index and bleeding in a large multi-center cohort of patients with acute myocardial infarction, suggesting that concerns about bleeding should not preclude the use of omega-3 supplements or increased fish consumption when clinically indicated. So this was 12 years ago, but nobody's listening, unfortunately, because the myth continues. More recently here, 2021, a nice study from a very well-known observational cohort study in the U.S. called the Multi-Ethnic Study of Atherosclerosis, abbreviated MESA. In this particular study, 6,500 people, healthy individuals with blood omega-3 levels were measured and then followed over 14 years for the incidence of major bleeding events based on hospital-based records. And without going into all the details of the numbers, what they concluded here is shown in the bottom of the slide. For incident bleeding, consistent statistically significant associations with lower rates of bleeding were seen with increasing levels of EPA and EPA-DHA in both adjusted and unadjusted models, including medications that modulate bleeding risk. So here's where we begin to see, and you'll see soon that we've seen this before, higher omega-3 levels actually associated with lower risk for any clinically significant bleeding, which is obviously contrary to the standard story. Let's look at some non-randomized trials now. And this is a trial where you retrospective, for example, this study here from Watson in 2009, they were determined whether fish oil increases the risk for bleeding in coronary artery disease patients who were on dual antiplatelet therapy, so aspirin and clopidogrel at the time. So this was a retrospective chart review, bleeding complications, 182 patients who were on dual therapy with 2.5 grams of EPA and DHA as the recommended intake. And they compared them to 182 controls who were only on antiplatelet therapy. And this figure on the right shows what they found. The percent of people who are experiencing major bleeds or minor bleeds is shown here, and essentially no difference at all in major bleeds between the fish oil group and the aspirin group. Statistical p-value of 1 is no difference at all. And here in minor bleeds, the p-value is still non-significant, but there are actually a few more people in the aspirin group that had major or minor bleeds than on the fish oil group. So they concluded high doses of EPA and DHA, and this was around 3 grams, in combination with antiplatelet agents, did not increase risk for clinically significant bleeding. Here's another one, a completely different setting. Here's omega-3 supplements and bleeding during spinal decompression surgery. It's a small study, but they were looking at 16 patients who had been taking fish oil supplements within the 2 weeks before surgery, and they stopped 2 days prior, which is irrelevant because omega-3 levels stay up for many days after you stop taking them. They were compared to 79 people who had not been taking fish oil, and they looked here at the estimated blood loss during surgery between the control group and the fish oil group, and there was no difference. You can see 150 mils, 140 mils, no difference at all. And then in this paper, they did a quick summary of the literature available at that time, 5 different studies in surgical settings. And if you look at the results over here in this red box, no difference between the control group and the omega-3 group for any bleeding outcome. So this, again, set the stage for the evidence says no increased risk for bleeding in surgical settings, which is really where people are often concerned about it. Kepler and all actually said this in the end of their paper, although past conservative recommendations based on likely clinical effect are prudent, when no clinical information is available, like maybe if we don't know anything, we assume bleeding might be higher with omega-3. But they said our developing understanding of the risk associated with omega-3 fatty acids suggests no reason these supplements should be stopped before surgery, nor why surgery should be canceled when a patient fails to stop taking them, which is something that has happened. So they're saying, don't do it. Don't worry about it. Fish oil is going to be okay. Randomized trials, getting a little bit better, stronger data here. Well, I'm going to start with a trial that was done by giving fish oil supplementation to determine the effects of the treatment on synthetic hemodialysis grafts. Of course, when people are on hemodialysis, they sometimes put a vein graft in, which makes it easier for them to 2 or 3, 4 times a week to stick in the dialysis needles. So they had these grafts, and the question was, does giving omega-3 improve the duration of time that the graft stays open and working? That was the idea. And this was published in JAMA, so this was a serious study. The title, Effective Fish Oil Supplementation on Graft Patency and Cardiovascular Events of Patients with New Synthetic AV Hemodialysis Grafts. Randomized trial. So what did they have? 201 patients randomized to either 2.6 grams of EPA and DHA a day or placebo 7 days after their graft was created, and they were followed for a year. And then there was quite a few of them were on anticoagulants, 50% on aspirin, 24% on warfarin, 12% on clopidogrel. And here's what they found. This is the figure. The fish oil group is in dark bars and the placebo in the light bars. This is the events per 1,000 days of access, and there's significantly less primary events in the fish oil group, significantly less thrombosis, significantly less need for other interventions, and really no difference in cardiovascular events. There were too few to be statistically significant. They conclude their paper, although fish oil improved some relevant secondary outcomes such as graft patency, rates of thrombosis, and interventions, other potential benefits in cardiovascular disease require further study. So they do say fish oil improved the rates of thrombosis, meaning it reduced risk for thrombosis. It wasn't just no effect, it actually improved the outcomes. Here's another situation that we were involved with. This is called the OPERA study. It was a study where individuals who were undergoing open heart surgery were given omega-3 before surgery to see if they could prevent post-operative atrial fibrillation, which is a common outcome after open heart surgery. Dario Mozaffarian was the lead author on the major study. This is a secondary analysis I'm presenting here, but we had 1,500 patients who were undergoing open heart surgery. International study, they were given 10 grams a day of EPA DHA for 3 to 5 days before surgery. Because typically this is a emergency surgery or very urgent, so you don't have you don't have weeks and weeks to give people omega-3. You have to give it quickly in high doses before the surgery. And then after that 3 to 5 days of 10 grams a day, they were given 2 grams a day until they were discharged post-surgery. And the primary outcome, as I mentioned, was post-op AFib. The secondary outcome was a safety outcome, was their bleeding. And the primary outcome, AFib, there really was no difference. The omega-3s did not reduce or increase risk for AFib post open heart surgery. But the bleeding outcome is what I want to show here. This is a list of the bleeding. Here's the primary one that's worth looking at. The total number of units of blood transfused, how much blood needed to be transfused during the open heart procedure. And what they found with fish oil, about 1.6 units, with placebo, 1.9 units. That was highly statistically significant. Whether it was during surgery or after surgery, same thing. So at the end of the day, we found less need for transfusion in patients treated with omega-3. So that obviously the omega-3s are not increasing the risk for bleeding. They're actually decreasing it by mechanisms not really yet understood, perhaps anti-inflammatory effects. Another randomized trial, this is individuals who are men who were undergoing prostate surgery. And the question here was, again, what's the effect of omega-3 on perioperative blood loss during prostate surgery? And here is one of the primary outcomes, is table 2. We're looking at HOSO is the placebo group, high oleic safflower oil. It's a vegetable oil. And here's the EPA intervention here. And the estimated blood loss in one group, in the control group, was 415. It was 385. Not significantly different. Obviously tends to be a little bit lower in the intervention group. Again, our results suggest N3 supplements can be safely taken before radical prostatectomy without increasing surgical bleeding risk. Okay, so the story is getting to be a little bit redundant here. It's going to continue that way as we continue down the story here. Meta-analyses, of course, it seemed to be the highest level of evidence, and we have a few to look at. First of all, in the area of pregnancy, this is a meta-analysis done by Dr. Olsen in Denmark, who has been studying the effects of giving high omega-3 supplementation during pregnancy on birth outcomes. So this is a study of 6 trials, including 1,600 pregnant women who were getting between 2.2 and 5 grams a day of EPA and DHA during their pregnancy. They monitored bleeding at delivery, and they concluded that overall supplementation reduced risk for preterm birth, which is a good thing, of course, which has been recognized recently. Did not significantly prolong pregnancy. Importantly for our topic today, there were no significant differences between groups in the incidence of vaginal bleeding, blood loss at delivery, or the lowest maternal hemoglobin level. So all 3 metrics of bleeding were not adversely affected in obviously bloody procedure called birth by giving a high dose of omega-3. So again, safety is clearly been shown here. Here's probably the most relevant. This paper was published not maybe a month or 2 ago in the Journal of the American Heart Association. This is called Bleeding Risk in Patients Receiving Omega-3, Systematic Review and Meta-Analysis. First author was Mustafa Javed. We had actually a omega-3, what do we call it, Omega Matters discussion with Mohammed Al-Khali, who was the senior author whose idea it was to do this study. I had a great discussion with him. So this study looked at patients who were randomized to omega-3 or placebo, studies that reported bleeding events, and studies that had at least 1,000 patients in them. So in that, there were over 120,000 patients included. 9 studies where EPA and DHA was the omega-3 treated or given. 2 studies, only EPA was given. So what did they find? So risk for any bleeding at all. There are data from this many studies. Here is the odds ratio. It's 1.09, which was not statistically significant. Essentially, there was no effect of omega-3 fatty acids on bleeding risk overall across these studies. We look at hemorrhagic stroke, another subset of bleeding. There was, again, no difference. Again, a tendency towards higher, and we'll see why that is in a minute. Intracranial hemorrhage, 4 studies reported no effect on intracranial hemorrhage. In this paper, they did a very interesting analysis. They looked at the difference in bleeding risk according to EPA dose. So here, this is looking at EPA, the amount of EPA given across these studies, and the difference in bleeding did go up. There was more bleeding with higher EPA dose. There's only 2 studies that gave high EPA, and those are the 2 that increased risk for bleeding. We'll see that a little more in a minute. And also, they also looked at the percent of patients on anticoagulant drugs, and they found here that the more patients, the more anticoagulant drugs were being used in these studies, the less the risk of bleeding, which is interesting. The omega-3s were effective in reducing risk for bleeding in that setting. So to summarize the paper by Javed et al., they said the incidence of any or central nervous system bleeding events was relatively low. It was about 2.6% for any bleeding in these studies and less than 1% for CNS bleeding, in other words, intracranial. Omega-3 PUFAs were not associated with an increased risk for overall hemorrhagic stroke, intracranial, or gastrointestinal bleeding. High dose, that is 4 grams a day, EPA, was associated with increased risk in bleeding, which a 50% relative increase. The absolute increase was 0.6%, meaning that the number of people that actually had a bleeding problem was 0.6% higher in the group that got EPA compared to placebo. And they say here the clinical significance of that bleeding was debatable. And finally, the bleeding risk was associated with the dose of EPA rather than the background use of antiplatelet therapy. So the risk for stroke is an issue, of course, that is a big concern. And if omega-3s contributed to that, that would be a bad thing. So let's take a moment and look at risk for stroke. First of all, look at the GELIS trial. GELIS was the Japanese EPA lipid intervention study from the early noughts, published in 2008. This was a study in 18,000, almost 19,000 Japanese individuals randomized to statin alone or statin plus EPA. They got 1.8 grams of EPA, which is kind of less than half of the dose that was given in the REDUCE-IT study, but 1.8 grams, followed for 5 years. They looked at stroke as a secondary outcome. They found out in this panel the risk for stroke for people who never had a stroke before. So this would be first-time stroke. And they found no difference between the EPA treated group and the non-EPA treated group, p-value 0.2. So there was no significant difference in outcomes for stroke. If you looked at people who'd already had a history of stroke, when they came into the study, of course, they had, over the next 5 years, they had more strokes than people who'd never had a stroke. But interestingly, the group that was randomized to EPA had a statistically significant lower risk of secondary stroke compared to the placebo group. So this means that, again, at best, EPA had no adverse effect at 1.8 grams a day. At worst, at best, EPA actually was effective in reducing risk for stroke. We look at the other EPA-only study in this meta-analysis. This is the REDUCE-IT study. And in REDUCE-IT, individuals high risk for cardiovascular disease were given 4.4 grams a day of EPA ethyl esters instead of 1.8 gram in the GELIS study. And they were followed for about 5 years for major outcomes. The one I have highlighted here, fatal or non-fatal stroke. And there were 98 in the EPA group, 134 in the placebo group. That's a 28% reduction in risk for stroke in individuals who got high-dose EPA. So there's no increased risk for stroke in either of these studies. There's actually a decreased risk for stroke with high EPA. I'll point out one other study that we were involved with, recently published by O'Keefe et al. This year in the journal Stroke. This was a part of a FORCE consortium, a group of observational study PIs that worked together. We had 29 prospective cohorts working together on this study, 183,000 people. We had median follow-up of 14 years. The exposure in this study was, we had all measured omega-3 levels in the blood at baseline, and then we followed up over years for risk for stroke. And over that time period, out of these 183,000, there were around 11,000 strokes, total strokes, 8,000 ischemic and 1,100 hemorrhagic. And so what was the relationship between omega-3 levels and risk for stroke? In this top panel, we have total stroke, and each of these lines is, we're listing the quintiles of omega-3. So the lowest people in the lowest quintile were the reference group, and then individuals who had higher omega-3 levels, the second and third quintile, fourth and fifth quintile, they had statistically significant reduction in risk for stroke as a function of higher levels of DHA. The hazard ratio 0.88 means a 12% reduction in risk for stroke. And interestingly, most of this was ischemic. Ischemic stroke follows the same pattern. Even hemorrhagic stroke was, the point estimates were certainly lower. It's just that the confidence bands were wide because there were very few hemorrhagic strokes to measure. So confidence intervals are wide. But the implication is higher risk for, higher omega-3 levels associated with lower risk for stroke. And that's what we found out here. Quickly, let's look at prescribing information. I think this is important because this is what the FDA is saying about the two pharmaceutical omega-3 products. We're not talking about dietary supplements, which are usually taken in much lower doses. Lovesa is the original omega-3 product that was, it's called Omacor in most of the world. In the US, it's called Lovesa. And this is the section out of the concerns from the prescribing information. They say some trials with omega-3 acids demonstrated prolongation of bleeding time. We saw that. Prolongation of bleeding time reported in these trials has not exceeded normal limits and did not produce clinically significant bleeding episodes. Clinical trials have not been done to thoroughly examine the effect of Lovesa and concomitant anticoagulants. Patients receiving treatment with Lovesa, again, 4 grams a day, and an anticoagulant or anything other drug affecting coagulation should be monitored periodically. Well, that's people who are on anticoagulants or other drugs affecting coagulation. They're always monitored periodically, whether they're on omega-3 or not. So this is a very benign risk statement. For Vascepa, it's a little more intense because there actually was some evidence of increased bleeding. Vascepa is associated with increased risk of bleeding, 4 grams a day. And then they review a double-blind placebo-controlled trial, 8,000 patients. This is the REDUCE-IT study. 12% of patients receiving Vascepa experienced a bleeding event compared to 10% receiving a placebo. So the absolute increase in risk was 2%. Serious bleeding events occurred in 3% of the patients on Vascepa and 2% of the patients receiving placebo. So that's a 1% absolute increased risk. Incident bleeding was greater in patients receiving concomitant antithrombotic treatments. And this was a 2019 update because the original one did not have any of this in it. So Vascepa definitely is something to think about. The absolute change in risk is very small. And this is a dose of 4 grams of EPA only. Closing anecdote. I am here at the end of the talk. I wanted to share this because I thought this was quite interesting. I'll begin with a recent publication. Schuhart et al. Have updated the world map of omega-3. You may not have seen this, published in Progress in Lipid Research earlier this year. This gives the best guess we have for what the omega-3 index is in different countries. I want to point out over here in Japan, no surprise, it gets a green light, meaning the very high omega-3 levels typical of that country. And that sets the stage for the anecdote I want to share. Japan is a high omega-3 level. My son was a physician on an Air Force base in Misawa, Japan. Misawa is up here in the northern part of the main island. One day there was some airmen got a little too drunk and had a terrible traffic accident. And they had serious injuries, several broken bones that couldn't be dealt with at the local base hospital. So they had to send them to a close by Japanese hospital where the Japanese surgical teams addressed their broken bones and eventually sent them back to the Air Force base at Misawa to recover. And one of the patients that came back to recover, my son was taking care of him, and this patient was starting to develop difficulty in breathing. My son thought, this sounds like a pulmonary embolism, meaning a blood clot that's formed in lower extremities and travels up to the lung and can block access to the lung for blood, which creates a difficulty in breathing. It can kill people. So pulmonary embolism is a very common outcome after major surgery. And so in exploring what happened, they contacted the Japanese hospital and said, here's what happened. This guy's starting to throw PEs, or pulmonary emboli. You put him on an anticoagulant, didn't you? Meaning heparin, because that's typically what's done in U.S. hospitals. Anybody who's having major surgery for any kind of major broken bones is always put on heparin to keep the blood keep it thin. And the Japanese hospital said, no, we never put anybody on heparin. We never have to. It's not part of our plan. So the point here is, because of the high omega-3 levels in Japan, increased risk for bleeding after major surgery is not a problem, because the blood is already anticoagulated with the omega-3. Put it in the U.S. context, typical American diet, which this guy was eating, of course, was not rich in omega-3, and so he needed to have an anticoagulant. So what we call normal bleeding or normal risk for bleeding needs to be contextualized to the omega-3